My name is Susanna Cahalan. I'm 21 years old, and here I am with my dream job at the New York Post.
Gross. Why are you smiling this early in the morning? It's unnatural and disgusting. You look ridiculous.
Susanna! You're gonna interview that creepy senator.
You'll have a Thursday night.
I know I will, because I can always count on you.
I had my whole life in front of me.
Happy birthday.
And I had absolutely no idea what was waiting for me.
Susanna, where are you? You're very, very late. You gotta get your ass in here. You're gonna miss the 10 o'clock meeting.
I feel really sick, my head hurts, the stomach hurts, and my hands numb, and I've never felt this before.
We've tested Susanna for every infectious disease. All of the results are negative.
We're gonna get to the bottom of this together.
Her EEG is completely normal, her MRI is normal, her neurological exam is normal, it's all normal.
Her condition continues to regress. Manic behavior, paranoia.
Each of them is giving us a different diagnosis. One is saying bipolar, next one is saying schizophrenic, then they're saying psychotic.
We should look at hospitals that are better equipped to deal with her.
Just take the pills.
She needs all of us.
We will find the answer.
Her life is in your hands. Tell me what is wrong with my daughter.
You must be the famous Susanna.
I'm scared.
I know she's still in there. She's just trapped.
I promise you, I'm going to do everything I can to find you.
No, God, no.
Time is of the essence. We are losing time.
Brain on Fire is based on the true story of Susanna Cahalan's experience suffering from anti-NMDA receptor encephalitis. The story follows Susanna's deterioration from an up-and-coming journalist at the New York Post to becoming plagued with voices in her head and seizures. As the weeks progress, so do Susanna's symptoms as she moves deeper into a state of insanity and her behavior shifts from violence to catatonia. As is the common story for many anti-NMDA receptor encephalitis survivors, Susanna is misdiagnosed by multiple doctors as being mentally disturbed with conditions such as bipolar and schizophrenia. It is not until a doctor's last-minute intervention enables the correct and rare diagnosis that she is allowed a chance to rebuild her life. The film displays the frightening nature of symptoms brought on by anti-NMDA receptor encephalitis and emphasizes the difficult nature of correct diagnosis of the condition. During this presentation, I will be talking you through the disease description, treatment and management options, as well as touching on limitations and future directions surrounding this condition. I hope by the end of this presentation you'll have a more in-depth understanding of anti-NMDA receptor encephalitis as a condition and are equipped with the knowledge surrounding the treatment and management strategies. The term encephalitis refers to an inflammatory condition of the brain. It has many etiologies. There are several types of encephalitis that are immune-mediated, including the classic paraneoplastic encephalitis syndromes and the encephalitis syndromes associated with antibodies against neuronal cell surface and synaptic proteins. The latter are often referred to as autoimmune encephalitis. The paraneoplastic encephalitis syndromes are almost always cancer-related, and the autoimmune encephalitis syndromes may occur in the presence or in the absence of cancer. This makes classification of encephalitis syndromes quite confusing, as the paraneoplastic encephalitis syndromes are autoimmune, and the autoimmune encephalitis may also be paraneoplastic. So, for this presentation, the term autoimmune encephalitis will refer to those syndromes which are associated with antibodies to neuronal cell surface and synaptic proteins. NMDA receptor encephalitis is classified as a form of autoimmune encephalitis due to its association with highly specific antibody-mediated immune response against extracellular epitopes of the NR1 and NR2 subunit of the NMDA receptor. This condition is more frequent in women, and it has associations with ovarian teratomas, and therefore it also has paraneoplastic activities. Autoimmune encephalitis is thought to be extremely rare. although in recent years the frequency of autoimmune encephalitis has been increasing. This may be due to advancements in the discovery and the use of diagnostic autoantibodies. Anti-NMDA receptor encephalitis was not defined until recently, and it's hard to determine the exact prevalence of the condition at this stage. Although, some cohort studies in America have investigated local prevalence. One study has found the prevalence of autoimmune encephalitis to be 13.7 per 100,000 people, with the prevalence of anti-NMDA receptor encephalitis being 0.6 per 100,000. These studies were conducted for the 2014 period. Another epidemiological study suggests that although rare, anti-NMDA receptor encephalitis is the most common cause of autoimmune encephalitis after acute demyelinating encephalomyelitis. Before I go into the pathogenesis of anti-NMDA receptor encephalitis, it is important to review the role of NMDA receptors in general. NMDA receptors are ligand-gated cation channels that belong to a group of inotropic glutamate receptors, which have crucial roles in synaptic transmission and plasticity. These receptors consist of several subunits, including NR1, which bind glycine, and NR2 that bind glutamate. These subunits combine to form receptor subtypes with distinct pharmacological properties, localization, and ability to interact with intracellular messengers. Alterations in expression and activity of NMDA receptors lead to various neurological conditions. It's proposed that overactivity of NMDA receptors leads to epilepsy, dementia, and stroke, while underactivity causes symptoms of schizophrenia. Anti-NMDA receptor encephalitis occurs when NMDA receptor antibodies cause a selective and reversible decrease in NMDA receptor surface density and synaptic localization. The mechanism behind this decrease is selective antibody-mediated capping and internalization of surface NMDA receptors, independent of the presence of complement and without affecting other synaptic proteins, AMPA receptors, or synaptic density. The magnitude of these changes depends on the antibody titer, and the effects can be reversed as the antibody titer is reduced. Additionally, the NR1 antibodies cause a reduction in NMDA receptor-mediated synaptic currents due to a selective loss of surface clusters, therefore decreasing glutamatergic synapse function without substantial loss of synapses. Reversible loss of NMDA receptors and the resulting synaptic dysfunction may underline the deficits of memory, behavior, and cognition, which are characteristic of anti-NMDA receptor encephalitis. The main risk factors include gender, age, and tumors. The majority of studies have found that anti-NMDA receptor encephalitis is more prevalent in women, with about 80% of cases occurring in women. Although there are also cases that show that men are also susceptible to the condition. Data also shows that younger individuals are more at risk, with the highest prevalence being in women less than 45 years old. And although rare, approximately 5% of patients are over the age of 45 years, whereas these patients tend to have a less severe disease, but outcomes are often worse, possibly due to a delay in diagnosis and treatment. There is also a large association between the presence of an ovarian teratoma in women and the prevalence of anti-NMDA receptor encephalitis. Although the condition can also occur in the absence of such a tumour, the detection of an underlying tumour is generally dependent of age, sex, and ethnic background. It's suggested that the younger the patient, the less likely that an associated tumour will be detected, with the highest rates of presence of tumour being detected in patients 19 to 30 years old. Additionally, women of African American descent are more likely to have an associated ovarian teratoma than patients of other ethnic groups. Although rare, tumour detection is not exclusively associated with women, as about 5% of male patients had an underlying tumour detected. A review of 400 patients with anti-NMDA receptor encephalitis found that only 2% of patients had a tumour detected other than an ovarian teratoma. Cases associated with tumours other than ovarian teratomas include testicular germ cell cancer, small cell lung carcinoma, Hodgkin lymphoma, and neuroblastoma. The frequency of underlying tumours found in patients greater than 45 years is relatively low, and when tumours are detected, they are more likely to be carcinomas rather than teratomas. Anti-NMDA receptor encephalitis is most often characterized by prevalent psychiatric symptoms and behavioral changes that are often accompanied by seizure activity, dyskinesias, and language dysfunctions. It's suggested that the clinical course of anti-NMDA receptor encephalitis progresses through phases. The prodromal phase, patients experience non-specific cold and viral-like symptoms, such as fever, fatigue, or headache, and after an average of around 5 days, patients progress to develop psychobehavioral symptoms. In the psychotic phase, patients now experience emotional distress and prominent schizophrenia-like symptoms. Commonly, seizures are also noted during this stage in a high proportion of patients. During the unresponsive phase, patients may develop a catatonia-like state where they are mute, unresponsive to verbal commands, but their eyes remain open. The hyperkinetic phase occurs last, and patients gradually develop dyskinesias at this stage. Additionally, patients also develop autonomic instability at this stage. Common psychiatric manifestations include anxiety, agitation, bizarre behavior, hallucinations, delusions, disorganized thinking, and are commonly misdiagnosed as schizophrenic behaviors. Patients may also have symptoms of insomnia, memory loss, decreased consciousness, and stupor with catatonic features. Additionally, those patients with autonomic instability may have hypothermia, fluctuations of blood pressure, tachycardia, bradycardia, cardiac pauses, and sometimes hyperventilation requiring medical ventilation. Patients generally respond rapidly once appropriate treatment is initiated, although in some cases recovery can be prolonged and complications may occur. Some documented complications include hypoventilation requiring ventilator support, persistent dyskinesias, prolonged recovery, brain atrophy, and amputations of lower extremities due to DVD and infections. Relapses also commonly occur. Additionally, the lack of treatment may lead to progressive neurological deterioration and death. There are multiple disorders that need to be considered as part of the differential diagnosis. The typical anti-NMDA receptor encephalitis patient is a previous healthy, young female presenting with acute, severe emotional distress and cognitive disturbances. There are many disorders that may be considered based on this presentation, such as acute psychosis, temporal lobe seizures, toxic and metabolic disorders, a focal brain lesion, or viral and autoimmune encephalitis. When considering a possible diagnosis of encephalitis, there are several important tests that need to be obtained in the initial workup. Although in saying this, a rapid diagnosis and appropriate treatment is crucial for optimizing the outcomes. Therefore, it is suggested that even before a neurological consultation is performed, one should consider obtaining serum and CSF for evaluation of viral and autoimmune causes of encephalitis. It is also suggested that an EEG and an MRI with and without contrast is also obtained. The diagnosis of anti-NMDA receptor encephalitis is confirmed by the detection of immunoglobulin G, IgG, antibodies to the NR1 subunit of NMDA receptor in serum or CSF. CSF IgG antibody testing is highly sensitive for anti-NMDA receptor encephalitis, although false positive and negative results can occur when testing with only serum. EEG is a monitoring method used to record electrical activity of the brain and involves electrodes which are placed along the scalp. In anti-NMDA receptor encephalitis, EEGs have been found to detect abnormalities in around 90% of cases, and commonly show non-specific generalized slowing, although in about 30% of patients a relatively unique EEG pattern has been noted. Although MRI is also indicated as a diagnostic tool, it is not sensitive for the detection of anti-NMDA receptor encephalitis, as only 1/3 of patients show abnormalities. There is often subtle contrast enhancements in the cerebellar or cerebral cortex, hippocampus, frontobasal, and insular area of the brainstem. Changes may be transient and might resemble demyelination. Anti-NMDA receptor encephalitis is an extremely debilitating disorder. Although when accurately diagnosed and treated promptly, death is uncommon. Early treatment is associated with increased rates of recovery, with approximately 75% of patients found to respond completely to tumor removal and immunotherapy. But in saying this, long-term effects may occur in a proportion of patients, with 25% of individuals experiencing residual cognitive and motor defects, and a relapse rate of approximately 25%. Rate of relapse occurs predominantly in patients who do not have a tumor or who are suboptimally treated with immunotherapy. The main treatment aims are to cure the condition, provide symptom relief, and to improve quality of life while maintaining physical and cognitive function back to a baseline. Treatment options include immunosuppression and tumor resection when indicated. Due to a lack of prospective and randomized data, treatment regimes need to be individualized and take into consideration the patient's age, presence or absence of a tumor, and severity of the condition. First-line options include corticosteroids such as methylprednisolone, which acts broadly to inhibit the inflammatory process. Although corticosteroids have less specificity for the antibody-mediated immune response, and their efficacy is limited in autoimmune encephalitis. Therefore, corticosteroids are not to be used as monotherapy, but in combination. Corticosteroids may also offer extra benefit to CNS inflammatory disorders by restoring the blood-brain barrier integrity and controlling brain edema. Immunoglobulin, or IVIG, provides antibodies to a wide range of pathogens and is used to provide passive immunity for patients with immunodeficiency. High doses provide various anti-inflammatory and immunomodulatory effects by multidirectional mechanisms, such as autoantibody neutralization, inhibition of complement cytokines and leukocyte migration, and it leads to accelerated IgG breakdown through the saturation of neonatal Fc receptors. Most adverse effects are mild and transient, although there is a risk of anaphylaxis in patients with selective IgA deficiency, but is extremely rare. Plasma exchange is also known as plasmapheresis. It is designed to exchange the patient's plasma containing the causative antibodies or toxins with physiological fluids or plasma. This technique has been proven to be a valuable immune modulator in a number of autoimmune conditions. The presence of a tumor is also associated with the production of antibodies which lead to the development of anti-NMDA receptor encephalitis. Therefore, where possible, removal of the tumor hopes to achieve removal of the source of the antibodies, allowing for immunotherapy to have full action and reduce the rates of relapse. Second-line options include rituximab, which is a partially humanized monoclonal antibody directed against CD20, a glycoprotein found on the surface of B cells. This causes depletion of both naive and memory B cells through antibody-mediated cellular toxicity, complement activation, and induction of apoptosis, leading to a reduction in activity of the autoimmune antibodies. One limitation of this is it cannot pass through the blood-brain barrier and may limit its therapeutic effects. Cyclophosphamide is also used, which is an alkylating agent which inhibits cell proliferation affecting both T and B cells. It's not typically used as an autoimmune to treat autoimmune neurological disorders and is less preferable than rituximab. There is many potentially serious side effects, such as myelosuppression and hemorrhagic cystitis associated with cyclophosphamide use. Symptom relief is also indicated and may include the use of antipsychotics, both typical and atypical, although these may complicate the picture, especially if given prior to antibody diagnosis. Sleep aids also used, commonly benzodiazepines, and in the case of catatonic symptoms, they're usually treated with benzodiazepines, with doses up to 20 to 30 milligrams of lorazepam daily being used in the past, although little is known about the efficacy of anti-NMDA receptor encephalitis. Up-to-date guidelines suggest the initial treatment for most patients should include IV methylprednisolone, 1 gram daily for 5 days, and either IV immunoglobulin, 400 milligrams per kilo per day for 5 days, or plasma exchange. In addition, tumor removal is highly recommended. The choice between IVIG or plasma exchange cannot be based on efficacy, as it is unclear if IVIG and plasma exchange have similar efficacy, but clinicians may find it easier to administer IVIG, especially in patients who are very young and have severe dyskinesia, agitation, and autonomic instability. When there is no evidence of clinical improvement with initial therapy, second-line therapies may be initiated. Second-line options include rituximab, either 375 milligrams per meter squared once a week for 4 weeks, or 1 gram given twice, 2 weeks apart, or cyclophosphamide, 750 milligrams per meter squared once a month for 4 to 6 months depending on results, or a combination of both can be used. These doses are for adults, and in children a similar treatment approach is being used. However, the doses of medications is less clear and is often adapted from the use of these medications in other autoimmune conditions, such as the use of cyclophosphamide in pediatric SLE. In cases of severely affected patients, it is increasingly favoured that an alternative approach to the stepwise escalation of immunotherapy is implemented. This includes the use of rituximab in combination with steroids and IVIG or plasma exchange as initial therapy. This is based on accumulating data supporting the effectiveness of rituximab in reducing relapses when used in second-line therapy. The following video documents Amanda's experience with anti-NMDA receptor encephalitis and provides insight into her symptoms, her time in hospital, and her recovery.
When I woke up, I didn't really remember large periods of time. I just remember just feeling very, very little in the hospital bed and lost.
On March 27th, 2014, Amanda became very ill.
I do remember not feeling well. I was having frequent migraine-like headaches that would actually kind of radiate down my neck, giving me, soreness of the neck. I wasn't thinking anything other than maybe stress.
She said, "I'm not crazy, but I can't sleep. I'm hearing things. Please help me." And then she'd wake up, and she always said she heard people talking to her through the lights, through the TV that wasn't even on.
I don't remember any of that.
On the 5th day of her not sleeping, family doctor said that we need to bring her to the emergency room at our local hospital. They told me that my daughter was bipolar or schizophrenia.
I think they thought I was also on some type of drugs. I was acting like somebody on
PCP or LSD or bath salts. That's how she was acting.
So they thought I was on drugs.
I said, this is just not her, and there's something really wrong with her. But when the psych doctor at the local hospital evaluated her, he said, we need to have her committed. They couldn't control her. She was trying to climb out windows. She kept saying she had to get to work. She didn't belong here. When you were in the psychiatric hospital, and my husband and I did get to see her, we went in the room, and her reaction was she didn't even know who we were. She did not know who we were. She came up to us, and I said, Amanda, it's Mom. And she just looked at me and she said, get me out of here, get me out of here, get me out of here. One of the tests that they did on Amanda in the hospital was a lumbar puncture. Within a week, we got a definite diagnosis that Amanda was suffering from NMDA receptor encephalitis. My husband and I looked at each other like we had no idea what that was. So we went home. I Googled all the information I could find on the NMDA receptor encephalitis, which isn't a lot. But we did come across the site from Penn Neurosciences, and they are the place that discovered this illness, and they're doing tons of research on it. And we decided that this is where Amanda needed to go. So I came back to the hospital, our local hospital, and I said, we need to get her transferred to Penn right away. Unfortunately, they didn't agree. They thought that they could treat her. And I said, you get me an ambulance, or I'm just putting her in the car. Upon being admitted to Penn Neurosciences, I met Dr. Eric Lancaster and the team of doctors and nurses that work alongside with him.
Amanda was previously very healthy. When she first arrived here at Penn, transferred from an outside hospital, she was comatose and unresponsive.
He said to me the treatment is a combination of 2 chemotherapy drugs, Cytoxan and rituximab. And he said then after she gets all that treatment, when they start coming back, sometimes they don't know how to walk again, they don't know how to talk, they have to learn how to feed themselves.
I recall that she responded very rapidly, perhaps more rapidly than most patients, to the infusion of these second-line agents, and woke up from her coma within several days of that being started.
I mean, it all felt like a dream, like I said, with my mom. Everything was a dream, and I really don't remember much until like probably August.
I guess it was like 3 weeks after receiving her doses of rituximab that I went in the hospital, and the nurse greeted me as I walked through the ICU door, and she said, "Oh my God, wait till you see your daughter. She's sitting up. She's starting to talk." And I just couldn't believe it. I just stood there and my mouth dropped like, what? And I went in the room, and there she was sitting in the chair, and the smile on her face. I mean, and she gave me a big hug, and you don't remember, do you? And she just said to me, "Where am I? And what happened?" And it was just such a joy, because they told me she would be fine, and I got to see that she would be fine.
Anti-NMDA receptor encephalitis is a rare condition, and as such, knowledge surrounding the condition is not widely known about, making diagnosis difficult. In addition to a lack of education regarding the condition, the symptoms of anti-NMDA receptor encephalitis mimic those of psychiatric disorders, further compounding the difficult nature of timely and accurate diagnosis. Once again, due to the rare nature of the condition, there is not a huge amount of literature surrounding treatment protocols. Many of the protocols are based off immunotherapy that is given in other autoimmune disorders, and no clinical trial has properly evaluated the most effective treatment regime, creating a lack of established guidelines for the treatment of anti-NMDA receptor encephalitis. Current literature is investigating the possibility of genetic predispositions in anti-NMDA receptor encephalitis. One study has found minimal genomic inflation, indicating no significant population stratification. Although further research into areas such as this may allow for a more in-depth understanding of the risk factors associated with the condition and may lead to a timelier diagnosis in at-risk individuals. There is also some current research being conducted into alternative treatment options for treatment refractory cases of anti-NMDA receptor encephalitis, with one study concluding that bortezomib is a promising escalation therapy for severe and refractory NMDA receptor encephalitis. Thank you very much for listening to my presentation today. I hope you have learned a lot.